Our next presenter is Dr. John Croboy. Dr. Croboy is the director of the Rocky Mountain MS Center at the University of Colorado. Dr. Croboy did his undergraduate medical school and neurology training at the University of Pennsylvania and completed his postdoctoral fellowship at Johns Hopkins University School of Medicine. Today, Dr. Croboy will be sharing the latest in MS research updates with us. Dr. Croboy.
Perfect. Thanks, Pete. Thanks, everybody, for coming. It's nice to see everybody electronically, and it's especially nice to see so many nice, warm top half of your faces here in the audience today as well. Thank you for coming. I'm going to steal a lot of today's discussion from recent ECTRIMS, European Committee on Treatment and Research in MS. And oops, sorry. Got to figure out how this works. There we go. And so a lot of these slides will look alike, and really the credit for those goes to the gentleman I'll show you here in a moment. So this was just a couple weeks ago, October 13th, almost exactly, actually exactly, should know, it's my son's birthday, 1 month ago. And many of these slides were from Daniel Selchin, but the other ones were from me. I just want to briefly talk about research that's ongoing here, and some of this will be amplified later. Especially Tim alluded to the RISE DREAM study. These are risk factors in early MS, and also development of risk factors for multiple sclerosis. These are studies looking at first-degree relatives who are asymptomatic, first-degree relatives of people with MS, especially typically offspring or siblings of people ages 10 to 30. The DREAMS portion is the pediatric component, and trying to identify those risk factors for the very earliest signs that we can see on multiple sclerosis on MRI scans. And so we hope that we will be able to define a very, very early algorithmic strategy to identify people as highest risk. And as Dr. Vollmer alluded to, that's the most important time to try to get to people and potentially treat them to avoid the loss of brain function and brain volume over time. So when we ask you in clinic to participate, this will be for typically your children or your siblings between ages 10 to 30. Also, Dr. Alvarez already talked about COVID vaccines, and I wanted to just amplify one. There's an upcoming study being done by Tom Campbell, who's the head of the infectious disease COVID studies on campus. And this particular study is an interesting one because it's looking at our patient population as well as others who are immunocompromised. This is individuals who will be on medicines that alter the immune system, such as rituximab and ocrelizumab, Ocrevus. And it will give the monoclonal antibodies made by Regeneron. These are therapeutic antibodies against COVID as a prophylactic measure. We know that there are reductions in vaccine response to some of the patients on some of our immune modulating therapies and immune suppressive therapies. And the goal would be to amplify this by giving this as a prophylactic approach. So that would actually, that's just gotten approval, and we should hopefully have sort of more information about operationally how that's going to work in probably just the next couple of days. At ECTRIMS, there are quite a few studies, and there have been many in the last 5 to 6 years looking at whether or not we can use MRI scans, relapses, and changes on examination to understand what people's risks are for more long-term problems over time. And this is from an original article with Dr. Sermani and colleagues in Italy, looking at just MRI scan lesions, accumulation of lesions, as well as relapses after 1 year of therapy with typically interferons in this study when it was started. And then asking the question, can you predict how people are going to look, in this case, 3 years later? And they came up with a scoring system as noted here, where you could see a score of 0, 1, or 2 to predict a 1-point change on the EDSS scale, this expanded disability status scale, a 10-point scale of disability that we use quite frequently, and showing that those who had no relapses and only 1 or 2 new dots on their scan at 1 year were substantially less likely to have changes on their exam over time compared to those who had either a relapse or more than 3 lesions on their scan. This is an approach that has been increased over time with many other studies and many other groups around the world in Spain and elsewhere. And a number of different scoring systems have been brought up. The Rio score, the modified Rio score, which is not Rio de Janeiro, it's Dr. Rio, who's a Spanish neuroradiologist. The Magnum score, which comes from the European Neuroradiologic Group, and the Risk of Ambulatory Disability, or ROAD score. All of these take into account what people have had after 1 year of treatment, but the ROAD score also takes into account baseline activity. And I'm not going to go through this whole thing just to go through all that, but just to mention it's similar to what I just showed you for the scoring system that was designed in the Italian group. And they just compared all these different scores and asked the same kind of question, but now they're out to 10 years of disability data. And in this case, they're looking at the likelihood that you would be without a change on that disability scoring. And you can see with all of them, for people who have the lower scores, you see pretty much the same kind of effect. And so that if people have, after 1 year of treatment, and these are mostly people typically treated with interferons, if you have new disease activity, either radiographically, typically more than 3 or more lesions, and or relapse, your likelihood of having more disease activity and changes on your exam over 10 years is substantially increased. The importance of this is that at 1 year, you should be able to make a decision. If you're not using as highly effective therapies we'd like you to be on, that's a good argument to potentially be treated. And this was a study that was actually at ECTRIMS a couple of weeks ago, and they looked at this question and asked simply, if you look at people who fulfill what are called the Magnum's MRI criteria, 3 or more new lesions over time, or did not, were MRI negative, and then asked for people who escalated their therapy to something more effective, did that matter? And the interesting thing with this was that for the people who fulfilled 3 or more dots on their brain scan at 1 year, and they did not escalate their therapy, they did the worst. They are most likely to have disease reactivation. But interestingly, if you fulfilled the MRI criteria of 3 or more new lesions and got escalated, you did about the same as people who did not have MRI scan new lesion activity, at least 3 new lesions. And so if you, there's 2 ways to look at this. One is that if you escalate, that's a good thing. You look like just like someone who didn't have new disease activity. But more importantly, from their point of view, is that if you only had 0, 1, or 2 dots on your brain scan, it really didn't matter to escalate or not in this study. This was alluded to a little bit before as well. What's going on with the age of onset and what's going on with disease activity over time in various different cohorts over time. If you look at people in the Spanish study on the right here, who were diagnosed in the 70s versus the 90s versus the 2010s, the average age of diagnosis is actually going up. And what this probably reflects is what Dr. Shah referred to, is that there are a fair number of women, especially that are being diagnosed with MS, that maybe 50 years ago would not have been diagnosed, presumably because of MRI scans, which have really aided our diagnosis, and also the change in the diagnostic criteria. But in addition, on the left, we can see, this is from the Danish registry, almost 8,000 patients, and they looked at individuals over 5-year epochs in the late 90s, the early 2000s, and then 2006, 2010, just said, what's happened to them over time? And it turns out that the rate of disability accrual over time has actually diminished. And this likely reflects a variety of different factors. One is we may be detecting MS better, and maybe we're detecting more benign MS that would have been missed previously. Also, the diagnostic criteria have changed, and we're actually diagnosing more rapidly. But also, this is the era when we've had more significant disease-modifying therapy use. So it's probably some combination of those things, but the overall impact is that less disability over time appears to be more the norm now. And there's an important concept that's been discussed more in the last 5 years or so, and that's something called progression independent of relapse activity. So we all have this construct in our head that when people are younger, they have relapses, and relapses may or may not be associated with progression of disability, especially on this 10-point scale, the EDSS that I mentioned a minute ago. But that when people are older, they typically either stop having relapses and sort of stratify, or they may go into the secondary progressive phase, as discussed in detail by Dr. Vollmer, especially where there's loss of cognitive reserve over time. But that's probably overly simplistic. And the reality from many recent studies is that we can see progression of disability on this, especially this 10-point scale of the EDSS, independent of relapse activity, even very early in individuals. And so there are a couple different studies here that get at that question. This is from an Italian registry. There'll be 2 slides on this, almost 5,300 patients, very early diagnosis MS or even clinically isolated syndrome with the first attack of MS before full diagnosis, young patients, very low disability, short disease duration. And what they identified was that 45% over the follow-up period of time, which was 11 years, had some amount of disability accrual over time. And it turns out 45%, almost 2/3 of that was independent of relapse activity. So these are very young patients who are developing disability independent of relapses. And the things that were associated with that were older age, having a second attack, fully diagnosed with relapsing MS, and longer disease duration. Things that seemed to be relatively not associated with that were lower level of disability, greater time on a disease-modifying therapy, especially a reduction of 80+% in hazard rate, and lower number of relapses. So it is likely that early treatment reduced the risk of confirmed disability accumulation, both independent of relapses as well as associated with relapses. And just look at this number here, 27% of the total had PIRA, and this is early MS. And I mention that because in a totally different study, we'll see in a second, it's very similar. This is the same registry from Italy right here, though, same patients, same follow-up, same everything. And again, almost 2/3 of disability accumulation due to PIRA, but it's not the same. The Italians have actually done a very good job of separating out pediatric onset on the left, regular adult onset, age 18 to 50 or so, and what we call late onset MS, people 50 and older when they have their first symptoms of MS, accounts for anywhere from 5 to 9% of people. Over age 60, maybe 0.5% of people with their first symptoms of MS. And what you can see is that accumulation of disability, the likelihood of being free of that diminishes with age of onset. The pediatric population does better than the later onset MS. Notably, progression independent of relapse activity obviously does the opposite. So older individuals, people diagnosed with their first symptoms after age 50, are much more likely to have progression independent of relapse activity. And that's not terribly surprising, but look at the Barcelona cohort here. The Italian study showed 27% had PIRA of the clinically isolated syndrome patients. It's 28% here. So this is in 2 different large studies in different populations showing essentially the exact same thing. So early PIRA suggests a more neurodegenerative component that's happening very early, independent of this active inflammatory disease that we think of with immune-based cells rushing in from the periphery into the nervous system. They're both important, but we see a neurodegenerative component early. And this will get at later then the concept that we don't want to wait until someone has progressive MS in order to try to use neuroprotective or repair approaches. We probably want to combine those with the anti-inflammatory approaches that we use now. And if we get those kinds of approaches that will help with neuroprotection, we'll probably want to start those early. This is a couple of studies from the world of Tysabril, Natalizumab. The top one there is just an Austrian 15-year observational study showing that in general, people do well on Tysabril, a significant diminished annualized relapse rate while on treatment. Most people stop because their JC virus test becomes positive, putting them at risk of infection in the brain with PML. But notably, they had a very low rate of relapse in patients who switched to dosing every 6 weeks. And there are a couple of different observational studies that have shown very similar kinds of phenomenon. But now there's a phase 3 trial. This is a randomized controlled trial of almost 500 people who have been stable on Tysabril for at least a year. And then half were randomized to go to every 6 weeks, half stayed on every 4 weeks. And they showed pretty much that there was very little difference between the two in terms of relapses and MRI scan changes. They did have 2 patients in the every 6 week grouping that had very large amounts of new disease activity and were outliers in this respect. One which just had a significant new disease activity after discontinuing actually the Tysabril, and that's the rebound effect that was discussed before. And one patient with PML, this infection of the brain associated with JC virus, that there was one person who got that And they actually had increase of disease activity, in part related to that, and in part related maybe to the MS being activated. But if you look in both groups, an incredibly low relapse rate over a year in both groups, in both arms, in the 4 weeks and every 6 weeks. So it might well be possible that we could use Natalizumab, Tysabril every 6 weeks to make it easier to use. You have less infusions, be cheaper overall as well. And there is some data that it will reduce the likelihood of developing PML, the brain infection. There's more discussion of this now as well, with the possibility of doing that with extended dosing as well for ocrelizumab and rituximab, based on the phase 2 data from ocrelizumab showing that individuals who were treated for 18 months and then not for 18 months and followed that whole time, that there was not a significant increased risk, no rebound whatsoever for individuals who were followed for up to 18 months after stopping their last ocrelizumab. So it's quite possible we might be able to extend the dosing interval as well for the anti-CD20 drugs. And to pile on a little bit with Tim here in terms of using highly effective therapy early, this is from the Swedes, what they call their Combat MS study. And what they showed, and this is just the latest in a series of studies looking at people who are newly diagnosed and then went on their very first therapy. And then they will compare what happens to them after they've been on their first therapy for a period of time. And this is follow-up now for 5 years. And you can see that there are differences between people using rituximab, natalizumab, Tysabril, dimethyl fumarate, Tecfidera, and injectable therapies such as Copaxone and the interferons. And this is just the probability of being relapse-free. So the lower this goes, the more relapses there have been. And rituximab did better than natalizumab, which did about the same as Tecfidera. And the injectables clearly were less effective. This is just another example of the distinctions between the therapies and the differences that we can measure when you compare them from early starts. And the Swedes have been big users of rituximab over the last 10 to 15 years, as we have been. And this is an interesting study. It's difficult to really interpret it because there are so many other ways that things could be affected. But this is a comparison of the Swedish database, looking specifically at the population in Sweden compared to the population in Denmark, and asking the proportions of patients who are progression-free, confirmed at 24 weeks. And the notable thing is that in Denmark, almost everybody starts on interferons. It's just required as part of their national health insurance. Things are a little bit different in Sweden. Up to almost a third of patients will start on more highly effective therapy. And actually up north, with Frederick Peel and his group, it's like 50 or 60% of people will start on rituximab. But at the population level, comparing these over a period of time for the starts between 2013 and 2016, you can see that the likelihood of being progression-free is higher in individuals who are using the more highly effective therapies in Sweden than those in Denmark. And this was statistically significant. So even at the population level, broadly, you can show this as well. We already had a discussion of neurofilament, so I'm not going to go into that further, just to use it, show an example of how it can be used. There are neurofilament-light, intermediate, and heavy chains. And if there's damage from anything, brain trauma, Alzheimer's, multiple sclerosis, and other things, you may see leakage into the spinal fluid or into the blood. The levels that you see in the blood are substantially lower than they are in the CSF, but of course, it's more easy to get blood than it is to get CSF from people. And so now the third and fourth generation assays, especially the platform we use, the Simoa platform, can show very sensitively very low levels of the neurofilament light. And it's a marker then of damage that we can use to potentially follow populations. And the question is, can we follow individuals with that as well? And so there are several, quite a few articles, abstracts at the meeting about neurofilament light chains. And we know that with age, neurofilament light goes up over time. If there's an acute relapse, neurofilament light levels also go up. And so they just reaffirmed that over the age of 60, as well as having impaired renal function and elevated high density lipoproteins, you could have higher amounts. Interestingly, larger people, greater blood volume was associated with lower concentrations. And that was especially true in the age 38 to 60. So whenever you look at these, you always have to keep in mind, is this a big person, a small person, an old person, a young person, a relapsing person, a not relapsing person, in order to be able to interpret them. But there were other abstracts that look at things like higher baseline serum neurofilament-light. And it showed, for example, that if you had a higher baseline level, you have a higher risk of having relapse. Relapse risk also increased substantially if your baseline serum neurofilament-light increased, say doubled, the hazard ratio was much greater of having new disease activity. Persistent elevations in serum neurofilament-light in the first 5 years were also associated with poorer outcomes. And serum neurofilament-light levels at the time of clinically isolated syndrome, the first attack of MS, was predictive of a second attack as well as long-term disability. So all of these are very useful at the population level. The question is, are we going to be able to use these numbers at an individual level? And right now, the answer seems to be no. There are other potential markers as well that we might be able to use. And going forward, getting markers like this will be extremely important for making judgments about different therapies and the impact of therapies and whether or not to change the different therapies over time. And that gets to new therapies. The one we have the greatest interest in the very short run right now has to do with tyrosine kinase inhibitors. And just a little bit of background, and as Dr. Shah said, there will definitely not be a test on this. Tyrosine kinases are enzyme. ASEs are enzymes. And what they do is they transfer phosphate groups from one molecule to another molecule and then may take them back and forth. And they participate in specific signaling pathways. And so you might have one tyrosine kinase for one pathway, another for a different pathway, a third for a third pathway. And reversible movement of these phosphate groups is a major mechanism used by all cells in order to have proliferation of cells, differentiation of cells, and regulation of cell growth, and even regulation of programmed cell death. So these are very important in terms of signaling. There's many different pathways, and there are some that are very specific for different pathways and some that are less specific. And the ones that are of interest to us are the ones that would potentially be regulating those parts of the immune system, immune-based cells. And so this is a cartoon that shows the B cells, the B lymphocytes that we talk a lot about. This is the B cell receptor. It'll be interacting with an antigen on its surface here. And then a series of events will occur where there's stimulation of molecules inside the cell that the Bruton's tyrosine kinase will do the phosphorylation that I mentioned and convert those into other molecules, which then will have all these different impacts inside the B lymphocyte. Inhibition, specifically with Bruton's tyrosine kinases, which are important for the B cells, would be then turning down proliferation of cells, turning down differentiation, turning down some of the things that are important in producing problems with multiple sclerosis. But the important thing otherwise about these particular BTKs or tyrosine kinases is that they also have an effect potentially on microglia. Microglia are cells of the immune system, the so-called innate immune system, that are present inside the nervous system. They are already there. They're there when you were born. And they have an apparent effect not only throughout the lifetime of someone with MS in amplifying the inflammation inside the nervous system, but in older patients, especially with progressive MS, this seems to be a very important part of the pathophysiology when we know that the cells rushing in from outside the nervous system into the nervous system is vastly diminished. And so they could have a similar effect there, turning down microglial activation and these production, for example, of a variety of signaling molecules as noted there. So this has the possibility to have two different impacts on B cells as well as on microglia. And in the animal model of MS, that is what's been shown so far. So there's a non-Bruton's tyrosine kinase inhibitor that has already been studied, masitinib, in multiple sclerosis, in progressive MS, and there's data already from a phase 2 study showing a significant reduction in progression of disability compared to placebo. Just for argument's sake, that's a greater reduction in progression of disability than we see with rituximab or ocrelizumab in progressive patients. And there are a variety of different studies which have been done so far in relapsing patients with the Bruton's tyrosine kinase inhibitors affecting B lymphocytes and hopefully microglia. And some of these are very select, and there are multiple different molecules that are these small molecules that are being studied. Some of them are very selected for targets related to B cell function, some less so. Some bind very tightly as an enzyme and irreversibly. Some are actually quite reversible. And some are very on target and only affect one lineage, like the B cell, and some will maybe be a little bit off target, and then you could have more potentially side effects. So they're not all the same, but there are quite a few of them that are presently under study, and quite a few of them for multiple sclerosis. The best data so far is probably from ibrutinib. We have now 6 different studies that are about to start with tolebrutinib and fenebrutinib, and there are others as well being studied. And there's just a little bit of data that I'll go through here with. This happens to be with ibrutinib, the phase 2 study, looking at multiple different doses and looking at effect on MRI scans, showing that the high dose compared to placebo had a significant reduction in the number of lesions seen weeks 12 through 24. This was a 6-month study, 24 weeks. Relapse rate was not statistically different, but clearly looked different overall. And then also the annualized relapse rate in the higher group was different compared to placebo. In studies that were shown at ECTRIMS, there were multiple different studies, and I won't go through these in detail, but looking at the combination of the higher dose of the ibrutinib, in addition to looking at people with high versus low baseline serum neurofilament-light levels, and it didn't seem to matter. They have helped people with reduction in relapses and or MRI scan lesions, especially in either the high or the low serum neurofilament-light, although a little bit better in the high group for relapse reduction. Looking at the top up here, and again, looking at the higher dose, the pink on the bottom here, they were able to show in this particular study an effect on slowly expanding lesions. These are lesions that we see in older patients with progressive MS where they don't have a lot of new lesions, but the lesions can oftentimes slowly expand and actually run into other lesions, become confluent. And this is associated with progression. And they showed a significant impact on these slowly expanding lesions, especially in people with a slightly higher disability level and longer disease duration. Again, suggesting that potentially this would be beneficial in older patients with progressive MS. And this is just safety data from the ibrutinib and tolebrutinib phase 2 studies, showing that the reality is that they're very safe. These are small molecules. They cross the blood-brain barrier. They get into the nervous system, and the potential for safety being good is quite good. And this is just one paper that was published very recently, and not with ibrutinib, but with tolebrutinib, and again, using primarily MRI as a major outcome level and looking at the higher dose compared to placebo, a significant reduction in new active lesions on scans. So a lot of that still has to do with how we approach the MS problem with immunotherapies. But we know that we would like to also potentially protect the nervous system cells from just dying, perhaps after they've already been injured by the immune system. So so-called neuroprotective approaches, which might include antioxidants or things that enhance energy production or other things like that inside cells, is very important, but also normal repair, remyelination, and also regeneration of damaged cells might also be important. And so neuroprotection refers to stopping the degeneration of cells inside the nervous system, independent of the actual immune attack. And there are several approaches which have been tried so far, are also still in study. Biotin, unfortunately, vitamin B6, or vitamin B2, sorry, in a large study was clearly negative and did not have an impact. Dr. Gross is still running our alpha-lipoic acid study, which is an antioxidant, and we'll hopefully have data from that in about another year or so. Simvastatin, as Dr. Vollmer already referred to previously, there's a second larger study being completed in Europe in progressive MS. The first study did show benefits in progressive MS patients, and then the BTKI inhibitors may also be considered partly neuroprotective. And there are a variety of other molecules being studied. I won't go through these in detail, only to mention that they are being studied. They're mostly phase 1 safety studies or phase 2 safety and efficacy studies. The bexarotene study will probably not go further ahead because of potential risk issues, but all of these are really focused on attempting to be neuroprotective, and there are others as well. There have also been a variety of molecules looking at remyelination. Unfortunately, remyelination studies have mostly been really pretty negative so far. Clemastine, opicimab, which is the anti-LINGO, has been abandoned by Biogen. But one that was briefly discussed before, metformin, in the animal models of MS might be not only neuroprotective, but also aid in remyelination. And the neuroprotective component would be as an antioxidant. There's a phase 1 study in children underway right now in Toronto, but also, again, Dr. Gross and our group just put in a Department of Defense grant to look at this as an add-on agent to individuals using the anti-CD20 agents and looking at the neurofilament-light in the serum as an outcome measure. And so hopefully we'll get that grant. We'll be able to try and get an idea of whether or not that will be useful as an add-on agent. And I want to briefly mention stem cells. Stem cells mean a lot of different things to a lot of different people. There's a lot of discussion about the use of them, not just in cancer, but in other conditions, especially autoimmune disorders. And a little just basic biology about stem cells. A totipotent stem cell can make an entire individual. That's essentially a fertilized egg. A pluripotent stem cell can make all but the fetus. An example of this is the placenta. But as there is development of the fertilized egg out into becoming a human being, a full human being with all different organs, cells will become differentiated and go down different tracks, different lineages. And these are then multipotent stem cells when they're gone down a lineage, including neural precursor cells that can become parts of the nervous system. And that's true for the kidney, the liver, the heart, and every other organ system. But these are the ones we're interested in because these would potentially regenerate nervous system tissue. And so the multipotent cells are those that may become brain and other tissues, heart, bone marrow, etc. And the sources of these precursor cells or stem cells could be coming from embryos. The problem with these, of course, there's ethical issues with getting these from aborted fetuses. They might be the best source in terms of the tissues themselves, but they're ethically challenging and are perhaps the least available. You can also get them from placentas, easily available, no ethical issues. You can also induce them. They're expandable, and that's a potentially good source. But you can also get them from adult tissues. You can get them from the so-called bone marrow stroma, which I'll show in a second on the next slide. But you can also get them from fat and other tissues. And you might be able to induce them to go backwards along that chain, go up to become a stem cell, and go down a different lineage to become neural precursor cells. And someone won the Nobel Prize, a professor in Korea, about 10 to 12 years ago for showing that that was possible, inducible pluripotent stem cells. So the bone marrow stem cells, which is where a lot of them are derived from, can become either hematopoietic cells like white blood cells, et cetera, or any of a whole host of what are referred to as mesenchymal stem cells, which actually can go to become, go down the lineage of multiple different lineages, including the central nervous system lineage. And so we can get bone marrow-derived stem cells that would potentially reboot the immune system. And there have been many studies now showing that in patients who are young with highly active relapsing MS, especially those failing traditional therapies, that in fact it's beneficial. And we and others have written reports suggesting that this should be considered a standard therapy for those who have active disease failing, especially highly effective therapy. And we're doing a study right now called Beat MS, Best Available Therapy in MS, where you look at patients with very active relapsing MS, 2 attacks within 3 years on disease-modifying therapy, and half the people be randomized to go into the chemotherapy plus stem cell rescue program, and half will get the best available therapy being, in this case, any one of the monoclonal antibodies or cladribine. And this is a randomized controlled trial. In addition, though, you could also have neural precursor cells, and these cells would potentially be injected into the spinal fluid, and they would hone their way into the various locations of damage in the brain or the spinal cord, and they would either replace the damaged cells, or more likely, they would have growth factors that they would bring with them and stimulate the cells that are already inside the brain, but which are not differentiating fully and which then could go on and become fully differentiated cells and recreate the network that's lost, as described by Dr. Vollmer with the cognitive reserve. And those are phase 1 and 2 studies that are underway. And just in terms of just a recent study, we've always thought in the last 5 or 10 years or so, when we looked at meta-analyses of all these different stem cell studies, that really it was only for great use in actively relapsing patients, especially younger patients, and the data for progressive patients didn't show much, and that's in fact what has been shown. But perhaps younger patients, in this case a mean age of 38 years, but still a significant disability on a 10-point scale. This means using a walking stick on average. In this study, when you looked at people on other disease-modifying therapies compared to those who got the stem cell therapy, the people with stem cell therapy did better in terms of their disability over time. About 20% of them actually had a sustained improvement in their EDSS compared to overall worsening overall with the other DMTs, and only 4% had any kind of improvement. And the suggestion here is that age and level of disability probably play a significant role in potential response to this approach. As many of you know, we've been for many years talking about potential discontinuation of disease-modifying therapies as people age, and there are 3 randomized controlled discontinuation trials. Our trial in the United States, which had its last patient last visit a couple of months ago, and we're just in the process of getting all the data inputted into the computers, and we will have this data available presumably around February. We're very excited to see this. Our population looked at all different patients with relapsing secondary progressive or primary progressive MS, but no relapses or scan changes for several years. Slightly different populations in France and the Netherlands. But between the 3 of these different controlled discontinuation trials, we should get an idea in which populations it would make sense, if any, to potentially do a trial off of disease-modifying therapies, noting that the natural history of the disease changes over time, and the medicines that we presently use that are presently available, and this might not be true for some new ones like BTK inhibitors, seem to wane over time in terms of their benefit. And I just wanted to mention one other thing to piggyback a little bit on Dr. Alvarez's discussion earlier about the messenger RNA or mRNA vaccines. That technology, that approach can also potentially be used in multiple sclerosis and other autoimmune disorders. The logic would be is that you would deliver the message for making a protein or proteins that were relevant to that particular disease process, and you would stimulate the immune system to turn down the immune response. And so this was published about 7 months ago in Science by this group here, Krinke et al., and showed that in the animal model of multiple sclerosis, you could use this approach as essentially a vaccine to treat multiple sclerosis, or in this case, really the EAE model of MS. So more will come on this later, but this is an incredibly exciting approach. Dr. Vollmer had a program going with a similar kind of approach with T cells and use of Copaxone and other medicines in the past. And this whole concept of using this as a preventive approach is extremely exciting if it bears out. So the main take-home points are taken here, and the main one overall is that the pace of research in MS is increasing, if anything. We've been very blessed in the last 30 years to have development of significant breakthroughs in treatment. And now we're talking about things that when Tim and I were in training would have been heresy, like the cells that are in the immune system or in the nervous system that could actually repair. We were told that those didn't exist. They clearly exist. They're in the nervous system. We need to find a way to unlock their potential to protect so that we maintain this cognitive reserve going forward. So thanks very much for coming today. We're going to take a short break, and then everyone will please come back and we'll answer all the questions. Thanks for your presence today.
Thank you very much, Dr. Croboy. Yes, we will take a very short break. We'll take just a 5-minute break. So please feel free to fill out your evaluations during that time, and then we'll get the Q&A started right after promptly the break. So appreciate it. Thanks.